Good
Great
morning,
to see
Brian.
you. Great to
Long
see you.
time.
Yeah.
Okay, so I am Dr. Manoj Chadha, consultant endocrinologist at PE Hinduja Hospital, and I have my practice at Navi Mumbai. And I have with me Dr. Brian Pinto.
Yeah. I'm the consultant cardiologist and the director of cardiology at Holy Family Hospital. Also practice at Breach Candy, Reliance, and Hinduja Hospital in Khar.
Great. So today, I think the idea is to discuss a little about what is happening in the diabetes world, and I think the focus now has been last 2 3 years on the diabetes and the heart and the kidney and the outcomes and what are the new medications available in.
Absolutely.
So
Absolutely.
that's be nice. So a little background, let me start. I mean, being the endocrinologist, that see, diabetes is a chronic metabolic disorder, and we keep talking about hyperglycemia and the types of diabetes. But what we have really understood over the years, one is we are dealing with huge numbers. I mean, every time the IDF comes up with certain numbers and certain projections in the next 2 decades, we seem to reach there in 1 decade.
Absolutely.
So, one of the focus now is to reduce diabetes, and obviously, we are worried about the complications. And I think that's where we come together, because we talk a lot about diabetes and heart. So, what do you feel about heart disease with diabetes and without diabetes?
So I think, Manoj, your question is very, very pertinent. In fact, when we see heart disease without diabetes, we are a little bit surprised.
Oh,
Yeah. So what we do is we look at them very carefully and see whether they have pre-diabetes. So this is basically the situation that we have. And sometimes we test them for that pre-diabetic state. So what we see is that if a guy has a vascular problem, within the next 5 years or so, he's going to become diabetic. So it's either the diabetic patient, which is almost about 60% of our practice, and the another 40%, most of them are pre-diabetic. And therefore, the problem, like you call that problem of insulin resistance. And I think, you've given numbers, but we believe that more than 60 million, and you can correct me, are diabetic people in India, and 120 million people are pre-diabetic. Now, having said that, we have, we believe, coronary artery disease to the extent of about 100 million people. Now, that's the whole iceberg, but the tip of the iceberg is only what is seen. So, really speaking, a population greater than the population of Germany, United Germany, are coronary artery disease patients in India. And that's the big issue. So, diabetes not only metabolic, but also vascular,
vascular.
vascular and metabolic.
Yeah, so sometimes
Yeah,
we have our cardiology colleagues joking
yeah,
that if you guys manage your diabetes well,
yeah.
probably our workload would go down.
Absolutely. We feel so. But I don't think those patients come to you also that early,
That,
you know?
yeah, so this we need to understand that diabetes is diagnosed, and so much of pre-diabetes,
It's
probably equal
existed.
number,
Existed.
is missed out. And I remember as a student we were taught about ticking clock hypothesis.
Yes,
That
yes,
much before the patient reaches us, the
yes.
problems will start.
All right.
So we have, I think, got the first part under control.
Right.
Manhattan or Mumbai?
This is Mumbai. And
Mumbai
look
makes
at the
sense.
waves. Beautiful.
Okay.
Really wonderful.
So, what has happened over the last, say, 2 decades? We've been talking about the ominous octet. We've been talking about the various effects in type 2 diabetes. And we've got a whole list of oral anti-diabetics. Let's not talk about the injectable anti-diabetics today. So, whether we are talking of the secretagogues, we are talking of anti-hyperglycemic drugs, whether they work on the liver, on the adipose tissue. Now we've got an interesting class which works in the kidney. In between, we had a class of drugs working on the brain, which never became very successful. And the alpha glucosidase inhibitors, again,
Yes.
good for Indian diabetics, but not very popular outside. So if you were to see in your practice, now you've been in practice for about 3 decades, uh, how is your use of anti-diabetics? I mean, as a physician cardiologist.
Though I'm an interventional cardiologist, Manoj, at my heart, I'm actually a physician first. then a cardiologist, and then an interventional cardiologist.
Fair enough.
So I treat diabetes not because I don't want to send it to an endocrinologist, because I think you're incomplete if you don't understand the biggest problem that causes vascular disease. And therefore, I've been in touch with the anti-diabetic drugs right from my early days. And so today, I think we are at a very, very exciting part of our spectrum of anti-diabetic drugs. So exciting that I think today we are not only looking at numbers of the blood sugar values, but we are also looking at prevention of vascular events. We're looking at saving the pump, which is the heart, and we are looking at saving the pipes, and we are looking at saving the filters, which are the kidneys. So really, we are now at that stage of our practice that yes, we want to look at the legacy effects. So we want to treat early, but we also want to use drugs which control diabetes, but also give us benefits in all these other areas. So the SGLT2s, the DPP4s, which have come in, and of course the secretagogues and all have been around for a long time. So you mentioned all of them, but the two classes of drugs, I'm not talking about the injectables, but now GLP ones have also become oral drugs. So that's another one that needs to be included. But clearly, what is available at reasonable prices are the DPP4s and also the SGLT2. So I think that's where the focus will be for the next decade, I feel. And the GLP-1s, if they start becoming cheaper, I think that will also add to our armamentarium. So I think the focus will now be in these areas.
I think you got the whole crux of the matter. Multiple drugs have to be used
Yes.
to take care of multiple defects, because
Absolutely.
diabetes is not like saying I had an infection because of a certain organism and I've treated
Absolutely.
it.
Absolutely.
So you need combinations, and you use the word legacy effect. Very, very important for us to understand, to convey. Go very, attack with the best thing that you have right at the beginning,
Absolutely.
so that you can prevent complications later on.
Yeah.
Another important point that you raised was the cost of therapy. I know it's expensive, but they have come down in the last year
I
or
agree.
so
I
by
agree.
more than 70-80%.
Drastically. And you're available now to, I would say, most Indians could afford both the SGLT2s and the DPP4 inhibitors. I think they can afford it now.
Yeah.
So I think using them upfront along with metformin becomes the crux of therapy in most patients.
And absolutely. And sometimes there's a situation that why do I need to use 2-3 drugs? I think the important thing is you're paying an insurance premium, health premium, to prevent complications later
Absolutely.
on. Because when we talk of cost of therapy, we don't need to look at 5-10 rupees for a
Correct.
tablet.
Correct.
The hospitalization, the complications,
The complications are multiple.
and the loss of man hours.
Oh,
See, these are things when we talk of cost
Astounding.
of therapy have to be considered. So it's very justified that we go in for the best that we have. Yeah, and tomorrow when the oral GLP-1 receptor agonist becomes affordable, probably we'll
Yes,
add that
of
into
course,
our
of
list. But
course.
as of now,
it's a little bit,
Yeah.
but for our top end patients, I think it's available. We have that
Absolutely.
group of patients
Yeah.
who
So-
can afford that. And but the important point which you brought out over here is to start early, start quite aggressively. See that you not only control numbers, but you also control complications. And I think this is the crux of treating diabetes. And of course, lifestyle. Like we climbed up over here to the fort.
we need to
This
do
is
that
we have
regularly.
to do this often enough. We got to be good on our diet also. Understand foods that are of low glycemic index, which can still fill up your stomach, but don't eat high glycemic foods. All these things are also equally important.
The bottom
I think,
line remains that
lifestyle
with
is so important.
lifestyle,
Yeah,
and you still kept metformin as the number one.
yeah.
Although
yeah.
there are some people who started
No,
talking
we
about
could go down in this thing in some patients, but I still feel metformin is a wonder drug, and you cannot leave it out unless the patient cannot tolerate it.
Yeah,
So there
that's
are few patients who will not tolerate it, but I think it's a wonderful, wonderful agent. In fact, I would say one more thing. Even to me, drugs like the glitazones in small doses, for example, pioglitazone, in a small dose, in some patients, not in those who have heart failure and things like that, but is certainly a metabolic drug. It gives you that edge, which allows you to get the sugars under control when people are metabolically inactive, as I would say. Not that they are not walking and all, but they have so much fat in them, they have so much this thing in them that they need to become metabolically active. And I think that's where a drug like pioglitazone does do, in a very small dose of which I never use more than 7.5.
No, no, it's a valid point.
Yeah.
We have somehow pushed it back because of
Yeah.
this issue about weight gain and
Yeah, but that's
edema.
only weight gain related to heart related issues, and that must be, you weigh the patient every week, tell him to weigh himself, he knows immediately. So I think the combination along with these other two agents can, and then we always fall back on our insulins also
When the time
when the time comes.
At
We
the
try
right
to
time.
avoid it. We try to avoid it as much as possible, but then when it has to be used, it has to be used.
Brian, 2008, there was a major change in diabetes with the rosiglitazone fiasco.
Yes.
And then the US FDA sort of made it mandatory for CV safety,
Absolutely.
that it doesn't hurt more than the placebo. That was the whole thing. And 2015, suddenly MPRA came out and said that it reduces mortality. It is actually helpful for the heart. And we saw good news with Canvas and with Declare. And now last 2-3 years, we are talking about SGLT2 inhibitors in diabetics, non-diabetics, heart failure, all there. So as a class, what is your thoughts been on, the use in cardiac patients, let's say?
So I'll start with that 2008 fiasco, and please remember that the person who really brought it to the table was a guy called Steve Nissen, a cardiologist who started looking at intravascular ultrasounds, which we do today, and saw that really this was hurting the patients more than benefiting them. And so CV safety came in, not just numbers, just not control of diabetes. And therefore, each of these molecules had to go through a very stringent kind of enough number of patients to be enrolled, enough statistical data to be provided, and then empagliflozin was the first one. But remember, it first showed benefit for heart failure hospitalization. It did not show MACE benefit right up in front. So clearly the SGLT2s came out as a drug in diabetics initially for heart failure. But lo and behold, what happened was that they started enrolling patients because they saw that this benefit extended beyond diabetics. And so they enrolled patients in new trials, and which had 60% non-diabetics and 40% diabetics, and found that the heart failure hospitalization was benefited even to non-diabetic patients. So today it has become one arm of the therapy for heart failure. So if you have a heart failure patient, non-diabetic, you still give this drug. So that's such a big change. And if you look at the change in the HbA1c for those patients, it's not more than 0.3. So they really do not cause hypoglycemia. That's another big part of the SGLT2s. There's that small thing about urinary tract infections that come up, but they're not so severe as what we think. More of them are fungal, as we have seen, and very few are really very, very stubborn. Of course, there's a group where you don't need to give them, for example, in people who are bedridden, so on and so forth, which we can talk about later. But what has come further is that the trials have now also shown great kidney benefit. In fact, the benefit from renal dysfunction, and I have started using it in patients with lower and lower EGFR, below 30, close to 25 EGFRs. And we are beginning to see that over 4, 6, 8 weeks, this benefit has started coming in. The point to renal deterioration has reduced significantly. And with this kind of benefit, both to the heart, the kidney, and also to the pipes, as I mentioned, atherosclerosis, I think the SGLT2s are on top as far as the cardiologist's prescriptions are concerned.
See, the interesting part, Brian, if you look at the onset of benefits, is so much before the A1C changes take place. And you said anyway, ANC reductions are 0.3, 0.5.
Yeah.
So there is something that is happening at
Of
the
course.
molecular, cellular level.
I can't pinpoint it exactly because there are so many benefits. You know that SGLT2s are on so many cells, not only they're on kidney cells, they're on heart cells, and there are SGLT1 receptors also. So clearly you know that, the sugar glucose transport inhibitors are going to work in a much more different way than what we were thinking of, whether they cause sodium loss, whether they cause water loss, whether they bring down blood pressure, whether they take care of diabetes, whether they cause vascular benefits. I think all this can be summarized, but I don't think we really hit the crux as yet. There are certain areas where you may, bring up certain points,
Right.
and I'm happy to
Yeah.
hear.
So
But there are large benefits that come out of these agents, which are beyond us at the moment to see, and I'm sure more and more details will come out.
last 2 years actually, going away from the heart and the kidney, one of our colleagues who's pretty big in SGLT2 inhibitors from San Diego,
Yeah.
he's been talking about the diabetes and eye effects with SGLT2
Yeah, I've
inhibitors.
read that
You
article.
read
Yeah,
Sundar Mudliar.
Yeah.
So this is something which you're going to hear and read more.
yeah,
But all in all, we do have a class of drugs. Leave aside the minor glitches. It's a wonderful drug in our armamentarium.
superb.
And again, repeating what we said a few minutes ago, with the reduction in cost of therapy,
Yeah,
I think practically every Indian diabetic has access to this
I
molecule.
would say, and to the DPP4s, which may not have shown as much cardiovascular benefit, but they're at least neutral. Number one. Number two, many of them are safe for the kidney, and you can use them in situations where your renal function has already deteriorated without changing the dose, which is so important. You give the same dose across any EGFR, and that's a wonder. The only thing is the pancreas in some few patients, which
That's
is
a
very rare.
one-off
It's a one-off
complication.
complication, but otherwise the DPP4s are also wonderful drugs. In fact, can be used when patients are lying on the bed. They're the first agents I add to an ICU patient after insulin, even before metformin, because I feel they're even safer than metformin. And then I bring metformin in later when the patient is mobile and things like that.
One very simple statement that we often use in meetings
Yeah.
is DPP4 inhibitors are a class of drugs that you can prescribe over the telephone.
Absolutely, like
Yeah.
amlodipine
Yeah.
for hypertension.
So you don't
So
really
multiple
need
drugs
to
for hypertension, multiple drugs for diabetes.
diabetes. So, Brian, we've had a lot of discussion on the do's and don'ts and what are the options that are available. But if you look at the guidelines over the years, whether it's the ADA, EASD, UK, Canadian, now our RSSDI, there has been a shift.
Absolutely.
As a student 35, 40 years ago, we were taught treat the glucose, control hyperglycemia. Now you mentioned protect the organs along with keeping the patient asymptomatic. So that's a major change. So probably when we look at what most guidelines says, divide your patients into those with ASCVD, CKD, very high risk for cardiac disease, cardiac failure. So what's your thought, and how are you using these guidelines in your practice?
I always believe that guidelines are a way to show us what to do in our patients, but we need to alter them to suit our patients and to get the best results for them. So, though in my opinion, still metformin remains upfront and that continues to be in the guidelines, but you will see that in some of the guidelines they would include SGLT2s even before metformin and a combination of SGLT2 and metformin. And clearly the DPP4s have also risen up in the guidelines. So these are the areas. And if you look at for cardiovascular, if you have ASCVD and all that, and you have kidney disease and things like that, the guidelines clearly prefer the SGLT2s and the DPP4s, and they've come up very high up in the guidelines. And that's why I think the change has occurred. These drugs were not available actually when we were students, and we used to switch to insulin so quickly in those days. But here we reserve insulin only for the acutely ill patients in the ICU for that time. Then we reserve them for patients who, after all these drugs, cannot be, the insulin is already exhausted completely from the pancreas, and you need to give them. So they go down in the kind of guidelines that we now have, and absolutely so. We've spoken a little bit about the GLP-1s, and sure, the GLP-1s oral will now come up in the guidelines also, because they will provide you stroke prevention. They will also provide you MACE reduction and major adverse cardiac events, and that's what the SGLT2s also do to some extent. So I think it's now protection, it's legacy effect, it's vascular control, and numbers. So you want to prevent microvascular complications also. So controlling sugars are also important, because you can't get away from the microvascular thing unless you control sugars as well. So that's equally important. So I would put it as a four strategy. Do everything you can.
So I think the two or three carry home from the recent guidelines 22 has been: one, you need to go a little aggressive right from the beginning and not the stepwise
Yes,
one,
yes.
two, three. The second thing is, irrespective of HbA1c, that's what the guidelines say. Irrespective of HbA1c in patients with ASCVD, CKD,
Yes.
heart failure, you should start with either SGLT2 inhibitors or GLP-1 receptor agonists. Having said all that, again emphasizing that metformin is our number one drug.
Yes, yes, yes.
If a patient tolerates it, metformin is the number one drug. We did mention about glitazones, useful drugs in selected patients. And please, we are not, sort of burying sulfonylureas for our practice. And with decades of experience, they are there for to stay. The guidelines also mention, maybe in small print, that when cost is a issue, because 10 rupees and then 1 rupee. So let's use it sparingly. Let's use it in a smaller dose and not the full dose that is written in pharmacopoeia books and in the insert package
And
insert.
but don't use the class one, the ones that were the earlier
No, I
sulfonylureas.
think they're out of
That out of the, though some
you
patients
have,
still get them.
yeah. So
So I think you got to use
the
drugs like gliclazide
glycoside
and
and glimepiride.
glimepiride. I think are the two sulfonylureas which you would want to. Don't use the older ones because they can cause much more hypoglycemia. These new drugs like DLP, like the GLP ones, the SGLT2s, and the DPP4 inhibitors hardly cause any hypoglycemia, which is very important. So the hypoglycemia is one of the killers for us cardiovascular people. If you have a patient in the ICU who gets into, you have more strokes, you have more myocardial infarctions, have more heart failure. So I think controlling sugar, but at the same time avoiding hypoglycemia is the crux to
Yeah,
the control of
I think
sugars.
so. If you look at when you want to go for strict control, weight gain is something that troubles our patients
Yes,
and the risk of hypoglycemia. And you're absolutely right. We would like a class of drugs where the risk of, so it's never zero, but
never
it's
zero,
less.
but much less.
So, we agree that we need more than one drug to take care of type 2 diabetes. But
Absolutely.
the Indian pharmaceutical industry has been in the forefront with fixed dose
Which I
combinations.
think has led the world as far as hypertension is concerned. In fact, this is what came out. ESC guidelines say you start with a fixed dose for more than 90% of patients, except for the elderly or those who have very mild hypertension. Otherwise, similarly, I think the direction is going towards. So, India has been smart in that. So, the fixed dose of, let's say, an SGLT2 and a DPP4 is going to be the way we're going to go forward, because you'll get a 1.5 or more reduction in the HbA1c when your thing is more than 8 or 9, and you'll also get the benefits and the vascular kind of protection from these drugs, kidney protection from these drugs, which you'll get right up front. And if you add to metformin in maybe what will come out as a triple drug combination, you'd possibly have, you may not start with the triple drug, but once you realize that you need all three, then you put a single pill on the table and the patients had it all.
No, no, we see over the years, we've realized that the compliance improves,
Yeah,
the cost of therapy comes down.
yeah,
And there is some suggestion that when you're using an SGLT2 inhibitors with the DPP4 inhibitors, on one side, DPP4 inhibitors suppress glucagon,
yeah,
whereas SGLT2 inhibitors increase glucagon.
yeah,
There has been some evidence to say that the risk of mycotic infections
yeah.
with the
Goes down.
combination also goes down.
Yeah.
So all in all, there are enough reasons, more than one,
To
that
say
you
that
should
we should
start
use
with
this.
using
Yes.
a fixed dose
Combination.
combination.
Yeah. Especially if the HbA1c is above 8 or 8.5. And I think that's clearly an indication for that. You know?
So if we were to sort of wrap up this whole capsule, we agree that it's a huge epidemic of diabetes, and we keep saying India is the capital or maybe the second largest community, and we don't have the resources to take care of our patients. So the first thing has to be prevention,
Absolutely. Lifestyle.
lifestyle, little less
Yeah.
stress on the brain, less running after numbers, and then
More
starting,
exercise.
yeah, exercise is very important. Starting early, you know let me wait,
Yeah.
let me wait more, those things should not be there. And going for combination therapy right at the beginning, we have the advantage, like we said, of our Indian pharma industry giving us so many
Wonderful
sane
combinations.
combinations, although there are a lot of
Yes,
nonsense
yes, yes, yes,
combinations.
yes. But that is the smaller number, and
Number,
they get weaned off actually.
yeah,
So
with time we come
with
to know
time
we
they
should
just
not
get
use.
weaned off.
Yeah, so the SGLT2 inhibitors, wonderful class of drugs. DPP4 inhibitors, a close second,
Yeah,
and the combination really useful.
very useful.
Okay. And the other drugs in selected patients should be kept in our armamentarium. We're not writing them off, but please see to it that there is some follow-up mechanism. Unfortunately, what happens is our patients become good, and then they don't want to come back for follow-up. Remember when pioglitazone went off for some reason, hundreds of patients came back saying, "Doc, this drug is not available." And
Now they do WhatsApp to you.
so I think we should call it a day.
Yeah, I think it's good. So Manoj, thank you very much. It was a pleasure,
Pleasure.
great
Nice
pleasure.
catching up.
Yeah, and I think we should have one more or few more such sessions
Certainly.
in the future.
Whether we do it on camera or
At
in one of
home.
our meetings. So I think we've been discussing a lot of positive things about SGLT2 inhibitors and DPP4 inhibitors. Let's discuss certain situations where we should be careful. I'm not saying absolutely contraindicated, that we'll see later on, but if we were to look at situations where we need to be extra cautious, uh, probably we are worried about urinary tract infection and more so about mycotic infections.
Yeah.
So past history, it makes it a little that we need to be careful. We need to talk to our patients very carefully, give them a little detailed instruction. I generally tell my patients that please remember, you may pass urine a little more often and you may feel a little more thirsty. The important thing is hygiene after passing urine, because you're passing sugar in the urine. So the hygiene part is important. And I think the number of infection cases are less than 5%. Literature talks up to 10%, but if you talk to your patients and take care, they generally do well. I mean, in your practice, for example, if someone does get an infection, I mean, what is your take on it? Do you totally stop the medication?
Yeah, so it's like this, as you mentioned, even in the urinary tract infections that you get with SGLT2s, I'm not talking about DPP4s over here. They are usually fungal infections around the prepuce of males by and large. So if a male is circumcised, I don't see those infections really, you know. And the real troublesome urinary tract infections are one where I take a history. Do they have multiple urinary tract infections earlier? Then I'm very careful not to start the drug. If a woman has been on, let's say, nitrofurantoin just to prevent urinary tract infection, and then you give her an SGLT2, I think that's a big no-no. Secondly, those people who are confined to bed, almost bedridden, I would not start an SGLT2 in this kind of scenario. And a third situation is where my patient is extremely down, and I would withdraw it when a person has acute infection. For example, has fever, has dengue, has COVID, though there's a trial now going on with COVID and SGLT2s. But I would not have the guts to start it in that, or I would tend to withdraw it at that time when a person has an acute infection, and then only use insulin as we usually do. As far as DPP4 are concerned, I would really not be worried across the spectrum to give it to them. In fact, it's the second drug after insulin in the acute ICU care that I use. But in those patients who have had pancreatitis, or in those patients who complain of abdominal pain, I am a little careful. So this is the care which I take with DPP4s. So it's like a telephone prescription drug, as you mentioned earlier. Very safe, very easy to give, and in fact, in case of linagliptin, it can be given across the renal spectrum. So even if a patient has, very poor renal function, you can give it. SGLT2s, on the other hand, if you dip below 20, the data is not there. It's not that I don't think you can use them, but the data is not there. So you have to be very careful. above 25, below 25 or so EGFR. But I think other than that, even in heart failure patients and all, you can in fact beneficially use them, you know, and they are the armamentarium for heart failure. So I would be very good to use them in that situation.
So there is this rare but very serious side effect of SGLT2 inhibitors called euglycemic ketoacidosis.
Yes. This is one area, yeah.
So probably there the doctor is to blame more than
Yeah.
the drug because it is wrong selection of the
Correct,
patient.
wrong selection.
Very often we are trying to try it in the LADAs,
Yeah.
the type 1s without recognizing.
Which don't actually fit for them.
Yeah, exactly. So that's why I said
Yeah.
it's the doctor's mistake and not the drug's mistake.
Yeah. Not
And
to be used in that situation.
Absolutely. And then, like you mentioned, any acute situation, you may get into trouble. The other thing is the SGLT2 inhibitors, they're a wonderful class in terms of bringing the requirement of insulin down. Someone is on 60, 80, 100 units of insulin a day. You add an SGLT2 inhibitor to the existing oral antidiabetics and the insulin requirements come down. And if you're too drastic in that,
you may get hypoglycemia.
You may get hypoglycemia if you don't reduce the insulin. But if you reduce the insulin very rapidly, you may precipitate an acidosis, ketoacidosis.
Okay.
So that's where we need to be a little
careful, I think.
When you're doing that. See, someone on 10, 12, 14 units, it doesn't matter. But I'm talking of 60, 80, 100 units, because there are patients. And I again emphasize that they really work well. So you use it, but be careful about that. The other situation now, recently there was an article on diabetes in patients aged 90 plus. So now we have patients living really long. So, that's where another place where, although literature talks that the elderly do well with SGLT2 inhibitors, I think we need to be a little careful on that part also. Yeah. A lot depends on how active
they are. If they are bedridden, no.
That is
even if they are 70 and bedridden, no.
So another thought that comes to my mind is hypertensive, diuretics, and then you add an SGLT2 inhibitor.
You need to control the diuretic, you need to control the antihypertensives, because you can drop blood pressure, you can cause more diuresis. So you may have to reduce the dose of the diuretic, you may have to reduce the dose of the antihypertensive. May not be too much, but a little bit. And you got to be careful about that.
I think, that's another
I think that summarizes more or less where we should not use this drug.
Side effect profile of SGLT2 inhibitor.
So, it's great once again.
Thank you.
Thank you so much.